Hello, hello, everyone. Welcome to a special, well, it's not a special edition of a Wednesday live stream, but it's our Lunch and Learn, which happens every fourth Wednesday of the month. So it's always exciting because, as you know, Liz and I are here every first and Thursday, Wednesday of the month for Ask the Experts. We answer your questions. We really kind of delve into different aspects of OCD and related disorders. But every fourth Wednesday, we have a Lunch and Learn where you have reached out to us through our Peace of Mind community, iocdf.org/peace of mind, and submitted not only questions, but also submitted topics that you'd like to see for our Lunch and Learn. So today we're going to be talking about orthorexia, and I'm not going to go too much into it because we have two special guests that will, so I'm going to let them introduce themselves. But before we jump into the live stream, a couple things. First and foremost, introduce yourself. Tell us hi, tell us where you're from, where you're located, maybe a little bit about you, what you're struggling with. We'd love to hear that in the chat. Are you a husband or a wife supporting your partner? Are you a parent of somebody with OCD and related disorders? Or do you have OCD and related disorders yourself? So we'd love to see where everybody's from, and we'd love to hear from everyone. So make sure you're putting in the chat where you are from, as well as ask any questions as the conversation goes on. If you have any questions about anything that is brought up in the live, please, whatever platform you're on, submit a question, and we would absolutely love to get those answered and tie them into the conversation. So a couple quick announcements. First and foremost, this live stream is educational, is not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online research directory at iocdf.org/find-help to locate a trained clinician near you. The IOCDF is not a crisis line. If you are in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. And we want to create a safe space and be kind and respectful to everyone. So at the end of the day, we are all here to support one another. And this is just a note, this is being broadcast on several social media platforms and is being recorded. So if you're new to our streams, my name is Chris and this is Liz McInville. We are clinicians who also happen to have OCD, and we are IOCDF advocates. So every Wednesday, first, second, and fourth of the month, we are providing you with OCD content. But today we have two very special guests. So our first special guest is Jason. So Jason, this is your first live stream with us, correct?
Yeah, this is the first one.
Absolutely. So how are you feeling today? Nervous?
Awesome.
Okay.
I woke up feeling great. I am super excited for this conversation. I've been waiting all week.
Absolutely. Well, why don't you introduce yourself? Tell us a little bit about, just a quick overview of just what brings you on today and why this topic is so important to you.
Yeah, so I have battled OCD as well as orthorexia for well over 15 years. It was something that, dates back to my teenage years. And I came to terms with everything. I was diagnosed back in the summer of 2020. And even at that point, I'd never heard of orthorexia before. That was not on my radar. I didn't know that that type of an eating disorder could even exist. So it was something that I realized in my treatment that I needed to get out there and start sharing my story, that I needed to raise awareness around this condition and confront some of those stigmas and stereotypes that prevent a lot of us, especially men, from seeking the help that they need. So I launched my blog, Orthorexia Bites, in 2021. I published my book earlier this year on my journey with orthorexia, and I spend a lot of my time out there talking with different audiences and just trying to change the narrative around eating disorders and raise this much needed awareness.
Thank you, Jason. We're so honored to have you. And then Kim Quinlan, a good friend of ours. She is a clinician out here with her own private practice here in Southern California, Calabasas. Right? Calabasas? Okay. And you also obviously have your anxiety toolkit, an amazing podcast that tackles OCD and anxiety-related disorders. We actually asked you to come on today because I know you've been kind of talking about orthorexia in the beginning, and some people may not know, but it's not currently in the DSM, so this is sort of like new territory. And so Kim has been doing a lot of good stuff on that, both podcasts and education articles, and also has CBT schools. So it is a way for people who can't access treatment to help themselves through cbtschool.com. So we're so excited to have you, Kim. Real quick, just kind of what brought you sort of interest into this specific topic? Because I know you've been doing stuff on it for a while now.
Yeah. So as I was becoming a therapist, I was actually working as a personal trainer. So you can imagine what kind of human being I was. I had compulsive exercise. I was so strict with diet. I had a very severe eating disorder. And one day, one of my clients actually that I was training said, "Have you ever heard of orthorexia?" I was like, "No, I actually haven't heard of this before." And I went home and researched it. I think she had perceived that I had it, but under the criteria, and I can already see questions here, under the criteria, I actually met criteria for anorexia more than I did orthorexia, but my behaviors were very clearly presented as orthorexia. And so then as I went into my training, I started doing more research and trying to like define where am I on this spectrum between the two. And so thankfully, I had all this OCD training, and it was a perfect sort of match for me to sort of look at this area of expertise.
Yes, and we're so excited to have both of you on. So I think that's a good way to start, Kim. Why don't you define orthorexia? So if people are out there watching this right now and maybe they're familiar with other eating and feeding disorders, anorexia, like you mentioned, bulimia nervosa, I mean, there's all different times that people experience and understand. For you personally, can you just kind of educate us a little bit on specifically what orthorexia is and maybe how it's a little bit different than the other disorders?
Sure. So the term orthorexia was coined, I think, in 1992. It's a fairly new term in terms of mental health. In the past, we've had these two categories. So you had anxiety disorders and eating disorders, and orthorexia didn't seem to fit well in either one because orthorexia is a preoccupation around food and the cleanliness and the purity of food. So it does mean that you will restrict food or restrict categories or food groups. You have a preoccupation with looking at labels and ruminating and planning, doing lots of food prep and so forth. So here, if we look, yeah, it looks very much like an eating disorder. However, we can also see that it looks very much like OCD, and that the obsession is focused on the purity and the cleanliness and the contamination of food. And so as we've progressed, thankfully now we have a diagnosis that does meet the criteria for orthorexia. We call it Arfid, which is avoidant restrictive food intake disorder. And ultimately what that is, it's a broad classification of different behaviors, and orthorexia falls underneath that. So yes, it's important as in the assessment process, and for people listening today, to sort of jot down your specific symptoms and speak to a clinician or a doctor, because the behaviors to having an eating disorder like bulimia or anorexia can look very similar. So you want to make sure that you're getting the correct diagnosis so you can get the correct treatment.
Thanks so much. I mean, that really helps clear it up because I mean, I think, if we can already jump into a question from Adam Bloom at
Can
12:03.
I hop
Oh, yeah.
in before we do questions, if it's okay, Chris? So
Yeah, yeah,
I
yeah.
would love for us to spend just a few minutes before we get into questions, just doing some differentials. So I would love for us to talk a little bit about when, Kim, we might diagnose Arfid without an eating disorder or disordered eating compared to when we would. And so what are some things that we should be looking for that would categorize somebody as, fitting a Arfid diagnosis, but not necessarily eating disorder? And then also it would be, we have to make sure we also talk about when OCD is thrown in the mix, and so how do we differentiate eating disorders from OCD, from orthorexia, Arfid, etc.?
So we'll use me as a first example. So I would only eat a whole wheat pita bread. 80 calories was my maximum for breakfast, right? And so that was all I was allowed to eat, nothing on it and so forth. And then my lunch had to be a salad with no dressing. And so here you could presented, we could say, all right, she could meet criteria for orthorexia, an eating disorder, or OCD, depending on the content of the obsession. For me personally, I was eating that specific diet because I was afraid of how it would impact my body size, right? And because I was very obsessed about size, body weight, how I was perceived. And so I met criteria for anorexia. right? And compulsive exercise. There was a compulsive exercise component. Now, had I been doing that, let's say I didn't care about my body size, but I cared about the health of my body, that I wouldn't want to put anything contaminated in my body, that the idea that if it wasn't organic or it wasn't a specific food group, well, then I would meet criteria for orthorexia. But I could meet criteria for both.
Especially depending on weight and other things.
Right.
Yes.
So if I was afraid of the purity and the health of the food, and I was worried about my body size, I could meet criteria for both. But then the presentation I had, let's say if my fear was, well, certain foods will make me vomit, and these are the foods that won't make me vomit, I may meet criteria for OCD or even a specific phobia called emetophobia, right? Or let's say you had criteria around foods with certain letters in it, or foods that had to be symmetrical and so forth. Well, then I would meet criteria for OCD and maybe orthorexia and maybe eating disorder if there was a preoccupation for food. So really the thing that we want to look at is the original obsession and the fear and what the content of that fear is. And that can help us identify where you fall diagnostically. The treatment may actually look the same across the board depending on the presentation, but it's important to find out what is that fear, what is the content of that obsession. What that will help us to define what is what.
I really appreciate that. And I just want to say thank you because, one of the things Chris and I talk a lot about and that we've really been trying to push in in our recent live streams, at least Chris, is differentials and making sure that we don't label everything as one thing, right? So if we see somebody presenting with struggles eating, we can't just assume you have an eating disorder. We need to understand what is at the core, what's going on, right? I did a panel on perfectionism yesterday, and we were talking about perfectionism can be generalized anxiety disorder. It can be OCD. It can be OCPD, right? But we need to understand more than just what we see at the surface. And Chris and I have been spending a lot of time talking about this when we talk about comorbid PTSD, when we talk about comorbid personality disorders with OCD, is how are we making sure that we're understanding the presentation of everything that can be going on and that we're knowing what is what, because it's critical when it comes to treatment, right? If somebody's presenting with disordered eating, that's actually but it's only OCD, and there's no other concerns, we're going to treat it very differently than if there's a diagnosable eating disorder or Arfid, right? And so it's just so important that we don't generalize labels and that we really kind of understand what exactly is going on, what diagnosis best fits or can best explain our presentation and our current symptoms, because that, you guys, is what leads you to effective treatment, right? You don't want to be doing evidence-based treatment for an eating disorder if you don't have an eating disorder and it's solely OCD. You don't want to be doing evidence-based treatment for OCD if it's not OCD and it's actually an eating disorder, right? Because they do look different. And we'll certainly talk about that when we talk about treatment later. But Jason, before we hop into treatment and questions, other things, we'd love to hear any input you have or thoughts around this discussion so far.
Yeah, so one thing that Kim brought up is kind of that motive behind the eating disorder almost. What's driving it? What factors are contributing to it? And that was something where I was able to very quickly differentiate and see that it was orthorexia, because it was this fear of cancer. I had a close call with colorectal cancer, and I was convinced that if I ate just one of those wrong things, then, that is what would contaminate my body and it would cause disease. And that was kind of that motivating factor behind what I was doing. It wasn't necessarily about weight or body image or appearance. I had insecurities about those things, but those weren't really, that driving force behind what was going on. And one thing that I like to say is when it comes to orthorexia, that it's more about the quality of the food rather than the quantity of the food. We so often see that with other eating disorders and assume that that's the stereotype that exists, but that's not the case. Sometimes individuals are more concerned about the actual quality of the food. There were times where I would go to the grocery store and they would be out of organic bananas, and I would get in my car and start crying and have a panic attack, an anxiety attack, because I was so fearful about eating these foods that I thought could do harm to my body. Based upon what I was hearing, from the various fad diets that are out there, or whatever you can find on the internet. We have we have so many great resources on the internet and a lot of information, but sometimes we have too much, because if you look hard enough, you can find something bad about just about any food out there, it seems like. And that's really what was driving, my orthorexia. And it was very important when it came to treatment. And I look forward to that discussion, because at first, when I was even just reaching out for help, I didn't know how to explain it to other people. I didn't really know what I was experiencing, because I didn't even know about orthorexia. I didn't know about these other types of eating disorders that existed. So it made it very difficult for me to explain to my treatment team what I was experiencing and what I was going through, which kind of served as a barrier to treatment there at the very beginning.
Yeah, we were talking a little bit before, and I didn't know what orthorexia was, and I didn't know I went through it so horribly. And so, my mom, shout out if she's watching, is a registered dietitian. So growing up, it was never about like how much food you eat, et cetera. It was a lot about like health decisions, like, drinking juice that was 100% pure fruit versus like things with high fructose corn syrup, or, selecting lean meats and things like that. And then I started running gyms, and there was always, like you're saying, Jason, like these fad diets. I brought out this book, I like dusted it off, because this book was like the book when I was working at the gyms. And so they have things in there like the importance of organic foods, specifically around corns and other foods that can be unhealthy for that, or the importance of good fats like almonds and avocados, or why it's better to have vitamins and nutrients from dark leaves versus light leaves, or why it's more important to have like whole grains and stuff like that, because it feeds your body. And so the reason I never could register it as a eating disorder is because I didn't relate to that. It wasn't really about calories. It wasn't about losing weight. To me, it was like, I have to be healthy, and this has to be my health. And I grew up in this mindset. And so it was only dark chocolate, not milk chocolate, because dark chocolate had, antioxidants. And so, one thing that you're kind of talking about in your intro is for men. I mean, talk a little bit about why do you think so many people miss it? Because I missed it. It wasn't until I had a client who was telling me about it, and I'm like, oh my God, I always thought it was OCD, because OCD was all about perfectionistic rules, and I related to that. It wasn't until my client educated me like 5 or 6 years ago what I personally went through. So for you, Jason, like, why do you think people miss it, regardless of sex, race, et cetera?
Yeah, so I think people miss it because they praise it. We live in a diet culture world where if you diet, if you eat healthy, if you cut these food groups out, you're doing the right thing. You have amazing willpower. And that's what I would hear. That's what I would hear from my primary doctor. That's what I would hear from my family and friends, that, oh, I wish I could be as disciplined as you, and as, as strong a willpower as you have. And that's why the concerns were never there. The flags were never being raised, because we've normalized so many of these orthorexic behaviors and tendencies in our society, just with the way that we talk about food. How many times do you go out to dinner and somebody says, ooh, I'm going to be bad tonight and have dessert? Well, that's what I was thinking too. The problem was I couldn't differentiate that. I couldn't realize that when I thought about dessert, it was an obsession, that I was, scared to have dessert. They were just saying this because it was part of their normal rhetoric. So I think that's one of the reasons why we so often miss orthorexia is, for starters, of course, we don't know about it. Not many people talk about it, but also the fact that a lot of the orthorexic behaviors that are out there are actually praised right now by society.
One thing you said was discipline. I mean, if I went somewhere and they were like, oh, sorry, the salad is mixed like romaine and iceberg, I just wouldn't eat the salad. Or like you said, if I went to a place and they didn't have organic fruit, I just didn't eat it. Kim, how do we get the word out more? I mean, how do people start to learn about this? Because what I hear in the community is a lot of people are like, well, I didn't know I had it because I didn't relate to the eating disorder component. It wasn't really about caloric intake or losing weight. And I didn't really think of OCD because it wasn't necessarily like intrusive. If anything, like Jason was saying, people get praised for it. And wow, I don't want to, I don't know what it's like in other states, but in California, I mean, every restaurant, it's healthy, and like, it's such an obsession out here with eating like pure and eating raw fruits and all that kind of stuff. So how do you get to that point where you get the word out more so people suffering from it can start to get help?
Yeah, I mean, I think there's multiple levels in which we have to attack this from. So, something like this today in a community level is really, really important. I think, again, I think it's a lot of education with medical professionals as well, because, again, they're praising behaviors that the person's looking at them suffering, right? That we want them and our teachers to be able to pick up on these behaviors of even young children, because it's happening even with young children, particularly when the parents are talking a lot about, good foods and bad foods. Anytime I hear a client talking about good foods and bad foods, it's always like a little alarm in my brain that, it's just a little assessment going on. I'm like, to what degree are they pursuing this good food, bad food kind of thing? It's particularly hard. I mean, the cool thing is there's lots of people on social media now that are starting to like call out companies that are marketing and trying to sort of spread this word on like good foods, bad foods, healthy, unhealthy, and so forth. So I think there's a lot of education that we are doing, and I think that's all we can do at this time. But again, I think it's also gently, if you're noticing people doing these types of behaviors, is gently asking curious questions, not pointing at them and saying you have. Again, in my case, like somebody asked the question, which got me curious, instead of saying you have orthorexia and that's what you have.
What the one thing too is, for us clinicians, it's not currently in the DSM-5. Do you presume that will help? Like if it's in the next round of DSM, just to kind of start to educate clinicians and clinicians going through schooling about it, since there's not really, I mean, there are articles on it, but not nearly as many or as many studies and stuff as a traditional eating disorder or OCD even.
Yeah, I mean, it would be nice. I think it would give. The thing about the Arfid diagnosis is it was typically a diagnosis given to infants who weren't latching with breastfeeding or wouldn't take formula. And so it was given for very picky eaters. And so the problem with this diagnosis, while orthorexia perfectly fits the criteria, it's very isolating for a grown adult man or woman to be like at the clinic with the mom and the newborn baby. So I think it is important that in the future we maybe can get their own diagnosis, just for the sake of a sense of community and not being alone, and the stigma it may break down as well. A lot of people I've spoken to with orthorexia feel like there's no real place for them. Like I don't really feel like I land in the OCD community, and I don't really feel like I land in the eating disorder community, and the alpha community is mostly babies. I think that's a really tough place to be.
Absolutely. I can relate to that.
Yeah. And I also want to note, that I think we're seeing an increase in awareness, and I think that people are talking about it now more than ever before. But again, the question is, can we see people talking about it appropriately? And can people engage in effective education and also send people resources that are going to be useful, right? That are evidence-based resources for treatment. And that's really why I'm just so grateful that we're doing this talk today and we're spending time, differentiating so that we can also get into treatment. So as we continue with differentiation before we get into treatment, there was a question at 11:03 from Adam. How can I tell what's OCD and an eating problem when it comes to purity of food and contamination? I think that's a great question, because can be both, right? This is where there can be a lot of overlap, where like the purity of food may be more Arfid, may meet more Arfid criteria, where contamination fears might more clearly meet OCD. So maybe Kim, if you don't mind taking that one.
Yeah. So from a clinical standpoint, let's say if I'm doing an assessment, a lot of what we do is what we call a rule out. So we're asking questions, and as we go, we're ruling things out. So I'll use an eating disorder as an example of, if someone presents very malnourished and obviously has, is struggling to get enough food, I may ask questions like, do you restrict your food? And if they say yes, I'll go, okay, so I've taken out like one, other parts of the disorder that could be happening, and I'll then go into the next tier. Okay, what is your fear around the restriction of food? Okay, I don't want to gain weight. Okay, so now we've knocked out orthorexia for the short term, and we can really look at, do some assessment for anorexia. Let's say they'll say, no, I don't care about my weight. I don't want to put anything, impure into my body. Okay, well, now we're going into orthorexia. We can ask some questions around that. The hard part with OCD is, okay, someone may present, they may say, I'm really struggling with meals. They may be malnourished, they may be underweight, and so forth. Okay, tell me a little bit about the reason, as Adam said, like what's the force that's causing you to struggle with that? And they may say, oh, it's definitely around the impurity. Okay, well then we've got some ideas around orthorexia being maybe what's going on. If they say, well, no, I struggle with foods that start with certain letters, or I struggle with foods from different colors, or I need the amount of foods to be a certain amount. A lot of people with OCD, they may be restricting, not because they don't want to gain weight and not because of the purity of the food, but their OCD won't let them have a certain milligram of things, or a certain package may feel wrong to them, or a certain food may have a texture that doesn't feel right, or may have, let's say, some magical thinking to it, like that texture may cause this bad thing to happen, and so forth. It could be, there's no limit to what OCD can attack when it comes to food. And so then, okay, now we're going to be looking more at identifying an OCD because we haven't met criteria for the others. And so again, it's sort of like this triage, and where we're just following the symptoms, and if it doesn't meet criteria for any of them, then we usually do land at OCD.
Well said. And I mean, Liz made a really good point earlier. That's one of the things that we've been trying to clarify on here, so that people can start to kind of really identify like what they're dealing with. And all this can sound the same because somebody may not eat something, 10 people may not eat something, the same thing. Why? That's what you're talking about right there, is really kind of ruling it out. And I know, you started a site, Jason. One of the things I related to what Kim said is, I know when looking at Arfid, I didn't relate because, as you were saying, Kim, I don't picture Arfid as like, I was probably like 22 or something when I was really struggling with it. I don't picture that as, Arfid. I mean, it's not who most of the time that you're talking to. It's mostly parents who have young children, really young children that aren't eating certain foods. So Jason, what have you seen in the community that you've kind of helped start with your website? Like, what are some of the people saying, or what are some of the groups of people that are really coming out and just feeling like they're finding a sense of community in the work that you're doing?
Yeah, so that was very important for me, because for those first couple months of treatment, I felt like I was on an island. First of all, I didn't really match the stereotypes of an eating disorder, being a guy, and we don't talk about guys battling eating disorders that often, let alone battling this unknown, mysterious eating disorder at that point that I didn't know, what to even call it. It kind of felt like it fell into that other category, or the none of the above when you're taking a questionnaire or something. So it often made me question whether it was serious enough, whether I was sick enough to even, seek help, because the last thing I wanted to do was take away resources from individuals who I did think were sick enough. So that was very difficult for me. And that's why when I started my blog, it was about building this community and about bringing people together who have those similar experiences so that they know that they're not alone. And it's been an incredible response. I have heard from individuals all over the world who have said different parts of my story have resonated with them and have changed their relationship, not just with themselves, but with food. They're learning what orthorexia is for the first time, that they've never heard of this condition before, that they're changing the way that they talk about food, that they're changing the way that they, perceive value in food, and the good versus bad debate that we've got going on with food. So it's been a great place, because people feel like they've been heard, people feel like they've been seen, and people no longer question whether they are sick enough for help. And for me, I think that was the most important thing, because I didn't want anybody out there who's struggling at all with their relationship with food. It doesn't have to be a full-blown eating disorder. If you have any sort of, anxiety or worry or guilt around food, talk to somebody about it. And that's kind of, that's what I've done with this group. But it's been really, really powerful to be able to lean on each other, and to know that somebody else has gone through what I'm going through, or, is experiencing some of the same things that I'm experiencing. I meet with several individuals throughout the week, and we just have, weekly touch bases, and we catch up about our lives. We catch up about our recoveries and our treatments. And it's a wonderful tool. It's definitely helped me in my own recovery, being able to connect with other people who can relate to my situation.
Well, and we're so grateful for you sharing your story. And this is really what these webinars are about, is just that we know treatment is important and critical, but advocacy plays such a big role. And, I think for you, Jason, being willing to speak out, especially as you said, being a male struggling with these things, it's just so important because it allows other people to be willing to relate, and certainly it's stigma reducing. So I know we're grateful for it. Chris, should we continue with questions? Or I think maybe I'll change the course if that's okay. And instead of continuing with questions, we will get to questions. I want us to hop into a little bit of treatment. So we're not going to go into OCD treatment because we've done lots of webinars on that. And many of you know that that's going to be ERP focused. So whether it is more emetophobia fears, or if it's OCD fears around maybe poisoning or contaminants or chemicals or contamination, right? We're going to do a lot of ERP. So we're going to actively have you face your fears without engaging in rituals and lean into the unknown that exists, right? We can't confirm or deny we're never going to get sick. It's always going to be safe. And we want to be able to live our life, live that values-based life without trying to be 100% certain, because that's where we'll get stuck. But let's talk a little bit about, so I'll share kind of briefly, and then Kim, or if anyone wants to add, for eating disorders, the real standard treatment is cognitive behavioral therapy. So there are eating disorder specialists, and oftentimes when patients are living with an eating disorder, we're going to recommend a treatment team. So maybe dietitians, nutritionists, as well as, potentially medical professionals, and a clinician who specializes and has background in eating disorders and cognitive behavioral interventions. And we want that needs to be a team approach, right? One of the big differences that I know we look for at our clinic when somebody has a previous eating disorder diagnosis is medical stability, because that plays a big role, right? If someone's not medically stable, we can't just start treating the eating disorder without worrying about them getting medically stable first, right? That takes priority. Just like if you're doing OCD treatment, but your safety's at risk or you're feeling suicidal, that takes priority before we start doing OCD treatment. Anything to add just around eating disorder treatment and kind of general background that would be helpful for those listening to make sure that they're thinking about and asking if they're seeking treatment for an eating disorder?
Yeah, no, so you perfectly, said we're always, anytime somebody's weight has dropped, significantly, it doesn't matter which disorder, we always want to make sure we get a medical assessment done first and get clearance to move forward. Because the pace in which we start to refeed is really important, right? If we do it too fast, that can cause some troubles as well. So it is important. Yes, in our clinic, we have a deal. If someone has an eating disorder, they must be seeing a dietitian in order for us to do outpatient weekly sessions, because that's like a standard of care. So absolutely, for eating disorders, that is the case. And I would say it's the truth for other disorders as well. When it comes to do you want me to go into the treatment now, Liz? Or
please, yeah.
So in regards to orthorexia, in fact, this is where it's actually really wonderful, in that we do have a lot of research now that with orthorexia, you're using cognitive behavioral therapy, but we actually use a large degree of ERP in orthorexia care as well. Now, we've also got research that ERP can be really beneficial for eating disorders as well. And in fact, in our clinic, we use a component of that as well for eating disorders, anorexia, bulimia, and so forth. So in this respect, whether you have any of these disorders, ERP can be very effective. But we also want to be looking at, like Jason has talked about, the impact of diet culture on the person with orthorexia. We want to be looking at, helping them get support, because a lot of times we've seen clients come in, the client has said to their family, I think I have orthorexia, and they've talked them out of having orthorexia because they know you are just healthy. You're one of the good ones, kind of thing. And so that has been, we want to create a lot of support and a lot of, hold their hand through that process, because that's a really painful thing to have to work through. So we do use a component of ERP, mainly not so much as pushing their fear directly into their face, but getting a hierarchy of slowly returning back to the foods they want to be able to eat in a stepstone way, and having it being done in a way that they get to choose, and in a way where they get to sort of gather themselves as they go up their hierarchy. The thing to remember here, and Chris said something I just want to mention, is with orthorexia, it may start really simple. I'm just going to cut out sugar. Okay, and then once you cut out sugar, the fear starts to like glom onto other things. Okay, we'll cut out fats. I'm making this up. It doesn't have to be in this order, right? And then it would be like, okay, only green juices. Well, that's the only, only juice, no more dairy, right? And then what it can do is it can even go even more specific on, it has to be juice that's freshly squeezed. Like it can't be squeezed 2 days ago. And then it could even like, it can get so subtle that it can be like, it has to be squeezed within the last 20 minutes. Because that's when it's, you could read an article online, like that's when the most optimum nutrient in absorption is freshly squeezed, like right in this minute. So the thing to notice is orthorexia sort of spreads like OCD, right? Slowly takes away food groups. And so with ERP, we may actually reverse that and slowly just start to do the things that you haven't been able to do and work in that fashion.
If I could add another question onto that we got about the treatment, since we're talking about it from Grace at 1209, how do you know whether to prioritize OCD or orthorexia? And then should somebody be getting a specific treatment center for orthorexia first and the, eating disorder and then OCD? I think that's what, Grace and others have the confusion is like, if they do have comorbid OCD, like how do you know when to prioritize? Can somebody with OCD treat orthorexia? Like how do you kind of navigate that in treatment?
Yeah. The beautiful news is that we can be putting together a treatment plan where the orthorexia and the OCD can be treated at the same time, right? We could either have 2 different lines of the hierarchy, or we could sometimes they're mixed and you can be addressing both as they go. However, a solid therapist who's trained in this will always know that when it comes to treatment, we always prioritize the health of the person, meaning medical. They need to be medically stable in order for us to go in that direction. So if for some reason you are severely malnourished, that would be the priority of treatment, is to get that piece, making sure that you're stable for treatment. So if that is the case, we would be first focusing on treating the part that gets them medical stable. Maybe meaning like this person maybe be so dehydrated because they haven't drank water in multiple days or weeks. Okay, so we have to get them hydrated first, and then that would be the thing we put priority on in treatment. So if that helps to sort of understand, it can be both. However, if there's a medical issue first, we would have to target that first. And it probably does require someone who's got training in both. The thing that's really difficult, and Jason may want to speak to this, is there aren't a lot of inpatient facilities that treat both, unfortunately. A lot of people will get denied treatment because of the medical concerns, which is exactly what they need, right? So we still have a lot of work to do in terms of providing, structures and places people can go with these disorders.
Yeah, when I received my diagnosis, and I was diagnosed with OCD and the unspecified eating disorder at the same time, I asked my doctor, I said, who do I go to? Where do I go for treatment and for help now? And sadly, he didn't know, because he said my situation was unique and that there weren't a lot of, options out there for individuals in my situation. So I had to basically go about piecing together a treatment team myself. And that was very challenging, because it was one of those things where it was almost easier to ask for help than it was to actually find the help that I needed. And I think that also played into that inner rhetoric that I was listening to that was like, are you even sick enough? Are you even worth going through all of this for treatment? So once I did start working with my therapist and my dietitian, it was kind of that, that dual approach. We were tackling both at the same time. And I will often say that my therapist helped heal that relationship with myself, and the dietitian helped heal that relationship with food. But I needed both of those pieces in my treatment program. So there were definitely days where it probably changed. And, we were working a little bit more on the OCD side of things, or the relationship with myself. And then there were other days where we were focused more on the food. So it definitely changes throughout the course of treatment, I think. But I think about those first couple days of treatment where it was just like, what do I do? Now what? That seemed to be the question that, you know, kept presenting itself to me.
Yeah. And you know, this is something that comes up all the time here is that, you know, we require a certain BMI for admission, and we require that eating disorder has been addressed, right? Because it's not just about BMI, it's about the fact that, like, are you currently dealing with an eating disorder as well? And it's not for us, like, if somebody is has undergone treatment for their eating disorder and their eating disorder specialist would say, like, OCD is ready and needs to be addressed right now, we would have them continue working with their eating disorder while they're eating disorder specialist, while they're here, because it isn't our specialty, right? We specialize in specific interventions for OCD and related disorders, but not eating disorders. And so we would encourage that collaboration of care, right? No one would want that to stop. But it is important to note that just like substance use disorder, it is hard when someone is living with comorbid eating disorder and OCD to kind of say, where do I start? What does that look like? And that's where, as Kim and others have mentioned, that team approach is really important so that they can really help guide that. Most clinics like ours, if there is a diagnosed eating disorder, we are going to want to talk to the entire treatment team, right? That the eating disorder specialist, the nutritionist, and really dietitian, and make sure that they feel the patient is ready to do active OCD work, just because there aren't a lot of comorbid programs. And I wish there was more, right? And I mean, we all do. We wish there was more OCD specialty and then all these other combinations, and it's getting better, but we're not there yet. So this has been great. We're getting really great comments, which is awesome. Thank you all for all of your questions. So I
have a question. If you at 12:19, we got asked by Rachel Binney, and maybe talking a little bit about, Kim, how to spot an Arfid diagnosis in kids. Rachel's basically saying, like, her daughter, some people are saying it is, some people are saying it's severe OCD and autism with a PDA profile. Like, how can you tell that someone has a diagnosis of Arfid?
Right. So I think that, can I see the question? I'd love to see it.
It was at, it's a long question, so that's why I might not be able to put on the screen because it blocks half of us. It's at 12:19. I'll read it real quick. It says, still battling.
It's from Rachel Binney, if you're looking in the comments.
I can see it. I can see it.
Oh,
yeah.
perfect.
So she's only eating bread products. All right. So it sounds, in this case, this is where, again, it can get tricky, is usually if there are multiple disorders, right, and we're also talking about having some autism, the best way to get real good clarification would be to have some kind of psychological testing. They can usually identify specifics, right? I do understand that that can be costly and it's hard to get those resources. Usually an autism specialist can help you to, because it is common, right? I think it's great that you're bringing this question, in that a lot of times with any kind of spectrum, we're looking there's a lot to do with pickiness. Like, I don't like certain textures or certain touch. This doesn't feel right or taste right. So I think the first thing to look at here is, again, what is the underlying, like, fear? Where is it coming from? Is it a sensory thing? Like, I don't like that feeling. Is it a fear around, again, contamination? Is it a fear that, because if that's the case, we would definitely look at OCD. I think the thing to remember here is, number one, often you will need multiple people. So we have had a similar case. We have someone who is specialized in autism and understands the sensory struggles they may have. And then we're there to sort of pick up what's not autism, and that seems to be more OCD. It may be hard to identify because the truth is these disorders can kind of interlock, and multiple disorders are playing on the same behavior. Example being avoidance of a certain food, right? So let's say it's the avoidance of applesauce because the texture is icky or something. That's just a very general example. The reason they avoid it could be because of OCD and Arfid for different reasons. So it's important there to have a team and collaborate. They said, unfortunately, they insist it's severe OCD and autism. I mean, again, if that's the case and they're insisting and you have access to an OCD specialist, they can actually be targeting orthorexia with some general training because they can use similar tools. That's something to maybe have a conversation with them about.
There's another good question at 1222 from Patricia, and maybe Jason, you could throw in there. What if somebody has this kind of orthorexia obsession with the cleanliness and purity of food, but they're displaying it maybe at home where they can read the back of packaging and control it, but don't have that same kind of focus when they're out at a restaurant? Because for me, it was everywhere. I mean, I was that person at a restaurant, and my family hated eating with me because I was changing everything. Can you use this type of bread? Can you use this? No mayo, this and that. Do you see in that, and you can always jump in clinically, if, Liz or Kim, but for you, Jason, like, do you see that people have it universally, or is it more so like, okay, when I go to the store, but at restaurants, I'm a little bit less picky?
Yeah, so for me personally, it was everywhere as well. It was something that I experienced, whether I was going to a restaurant, whether I was at home. It was every time I ate that I was experiencing those types of things. But in my conversations with other people, orthorexia can take on different forms, and it's different for everybody. And I think that's part of the reason why it's so hard to define it still, and to get that criteria that we need around it, because there's so much of a spectrum, and there are individuals who have different experiences when it comes to orthorexia. So I have actually come in contact with individuals who, they experience it kind of the other way. They experience it when they're at the restaurants, but when they're at home, they feel safer. So it is one of those things where I think it comes in many different shapes and sizes. And that's also why it's so often, I think, to define it sometimes.
I want to hop into a question that was pre-submitted. I want to make sure we answer this because this has been in our back-end queue for a long time. It says, when I research Arfid, it is often presented as something children experience, and there are weight requirements, etc. I don't fit those criteria, but the obsession, anxiety, restriction, and avoidance is 100% there. Are those requirements wrong, or is there an adult Arfid? We've been talking a lot about this. Or is it then a subcategory of OCD and it needs OCD treatment? Also, could EMDR therapy help Arfid-like symptoms? So apologize, 3 different questions in one. So the first question is really focused on how oftentimes Arfid presents for children and they don't necessarily meet those criteria. And we've talked a little bit about that. Are there subcategories of OCD would it then need OCD treatment? I feel like we've also talked about that, but maybe we could just brush up. But then would EMDR be helpful?
So I'll jump in really quick. So it is really unfortunate. And again, that's my concern with, under the Arfid diagnosis, I would say, yes, you do deserve to get that diagnosis, right? Because, or you want to call it orthorexia, that's okay too. Even though there's I think this is true for a lot of people with autism. We can use that as a metaphor of a lot of people. Usually when you talk about autism, you immediately think of a younger child or a preteen, but there are many adults who are just new to getting this diagnosis of autism, and that doesn't disqualify you for getting the care that you want. So I think that just remember, we're in an early stage of really understanding and getting education, and try not to use that as a reason to feel like you've been disqualified. For 100%, if you meet criteria for Arfid, I think that that's okay for you to use that if you're comfortable with that. So I wouldn't feel like you have to call it OCD just because it's often kids who have the Arfid diagnosis. In terms of using EMDR, we don't have a ton of research on that just yet. And there seems to be more research in terms of for Arfid actually coming from children and from other disorders, that by using more of a CBT approach, you can have often better, more effective outcomes. So, again, I think it's a matter of you reaching out to people in your area. And if you can find someone who has some training in CBT, that would be more beneficial. But I think it's also a matter of you finding a connection with a therapist that you feel comfortable with.
There was another question, and Jason, you touched on this a little bit, from Mitzi at 1231. Can this orthorexia arise out of or in conjunction with health obsessions? So their teen grandson has OCD. He struggled with health obsessions. Now he won't eat anything unhealthy. He also has to exercise a lot, has a timer on his phone to remind him and get up and exercise.
Yeah, absolutely. And this was something where I thought I was doing the right thing. I thought I was living this healthy lifestyle and taking care of myself, preventing disease, and doing what I was supposed to be doing to, live a long, healthy life. But it was becoming an obsession, and it was starting to impact all the other aspects of my life, my social health, my mental health, my emotional health, my relationships. It was starting to impact everything because I was becoming so dedicated to my physical health that I was allowing all those other types of health to just fall by the wayside. And I think that's something that we have to do as a society is redefine what health is. Because so often, if you ask somebody to tell you about health or healthy, it's usually physical health related. It's usually exercise or diet related. But we don't account for the other health, the holistic approach, the social health, and all of that. So it's one of those things where I think about the day that I deleted my fitness tracking app, which was a day of freedom for me. But it was something that I was living by for a very long time. I could not, take a day off from the gym without this overwhelming feeling of guilt or remorse that I was being lazy and not living the healthy lifestyle that I was dedicated to. And I needed to get away from that app. I needed to get away from all of that stuff. But it was very difficult because for so long, again, I thought I was doing the right thing. I thought that this was just, that healthy approach to live a perfect lifestyle. But the problem is it was going way too far.
We have quite a few other questions. I want to hop to the pre-submitted ones, Chris, and then we'll hop back to live ones. And some of them we can answer quickly. One of them is, by definition, is a diagnosis of orthorexia dependent on the reason you are exhibiting clean eating behaviors?
Yes.
Okay, great. Next question. I'm extremely concerned with food purity and contamination, what might be called orthorexia. How can I tell if it's OCD, which I have, or an eating disorder, which I also have, and does it matter in terms of proper treatment?
I think the thing to remember here, and I would say it for a lot of these questions, is it is commonly going to include both, right? Like we don't fit into little boxes, right? A lot of clients may present with health anxiety, like the last question, and then so they're trying to be healthy because they have health anxiety, and then orthorexia like gloms on, and you're managing both, and it can kind of whack and maul too, in that there can be waxing and waning of both disorders, and so that can be true for OCD as well. So I think the main thing is for everyone to sort of give again permission for it to be that it can overlap, that doesn't disqualify you, and that you don't have to fit into a special box in terms of diagnosis. Often, if you are going to a trained clinician, they will be aware that both will show up and that both can be treated.
And what I want to point out is that that's really kind of our job, right? Like it's our job as clinicians to be listening and conceptualizing and kind of picking up on if we're hearing things that sound different than OCD, and really exploring what is the core fear there, or like where is this rooted in, what's going on, so that we can recommend appropriate treatment. And so if you have concerns or questions, don't feel like you need to figure that out yourself. Talk to your provider about it and allow them to help navigate the process with you. Chris and I did a lunch and learn recently on PTSD and OCD, right? There's a lot of overlap. There's a lot of similarities in both. However, it's also important to understand which is which, because treatment might look a little bit different. And we want to make sure we're appropriately treating whatever we're presenting with. Next question is, can and should eating disorders be treated with ERP? In other words, is eating a feared food and sitting with it the same as to say as not checking a lock on a door and sitting with it?
So I'll jump in on that one. So yes, eating disorders can be treated with ERP. However, some people, you do usually need additional treatment, right? Additional modalities to support that, because Often people with an eating disorder are coming in with a strong diet culture mentality. It may be that again, we talked here before beautifully around, treating the self and the food relationship with food. That's a huge piece of eating disorder treatment. Can you use ERP and use your complete structure for your treatment? Absolutely. But as we go, there's other cognitive components you want to look at when it comes to treating eating disorders, particularly anorexia, bulimia, or binge eating disorder.
And then the last question is, how can I tell the difference between my OCD and my eating disorder? If they're hard to untangle, do you treat them separately? Do you treat them simultaneously? And what modalities? Which I know we've addressed a lot of this, but anything to add?
I think the main thing is eating disorders are almost always focused on preoccupation with body size, body weight, and perceived flaws of the body. And so if there is that, then yes, you would have an eating disorder or some type of eating disorder diagnosis. Can OCD be present alongside that? 100%. But if you meet criteria for it being preoccupied with body weight and size, that's usually the first diagnosis we would give.
I want to jump to this next question as well, because this is a newer one compared to other ones we've had. It's at 1144 from Lynn Skyla. It says, our daughter meets the criteria for restrictive anorexia and orthorexia, contamination, OCD, and ADHD. How would you tackle the orthorexic move to vegetarianism? We never were a big meat-eating family, but because of the OCD, do we need to do ERP around reintroducing meats? She is very resistant. Also, her OCD makes the movement compulsion, not resisting, hard to treat. Like others, we can't figure out how to form a team. We're based in Canada, and the lack of extensive services for these comorbidities.
Yeah. So this kind of goes off one of the other questions, and I'll jump on that. But Jason, please jump in if you want, is whether you have OCD, eating disorder, orthorexia, the real goal of treatment is to get you back to living the life you want to live, right? So I'm not going to stand over here and say you need to be able to eat every single food every single day. Oh, you're not recovered. That's not my place to say. Recovery is really based on you returning back to a value-based life. Now, there will be situations where the patient has restricted food because of their diagnosis, their orthorexia, but there's also a value around not eating food that's harmed animals, or maybe a religious value, right? Our job is to help guide the client back to value-based behaviors, and not step in and tell them what they have to do. But our job is also just to always be listening for when the disorder convinces them that it's their values.
That's right.
The disorder can be very convincing. So we're walking this just gentle line of giving the client permission to live their life according to their values, get back to the life they want, but also listening in for when the disorder is convincing them of something that's actually the disorder. It's a hard balance.
It's a hard balance, but it's critical, right? And we hear this and we talk about this with scrupulosity and with other things, is that the scrupulosity patient's fear of, like, you're going to take me away from my faith. Of course, that would be a valid fear if that was our goal in treatment. Our goal is to allow you to have a healthy faith relationship, right? And so what I want to know, Lynn, is the move from meat because of any of the disorders, or is it truly because that's a value, right? Because those are two different things. Values we want to honor, disorders we want to treat. The second piece I do want to say before we wrap up, Lynn, is do this with a provider, right? As the parent, I don't want you to get into the debates of what is it and trying to be the clinician and tease it apart. Allow the clinician to help do this together, and they should be working with you as a family to help guide you guys. And so you'll hear us keep saying that, but let's push it back to allowing the clinicians to help decipher, to help differentiate, both if you're the individual or the family member, because they really are the ones that should help you navigate this in an appropriate way. Morton, yes, this is recorded. You can go to IOCDF's YouTube channel and find all of our webinars where they are recorded, and you can find them later, any of the live ones to watch there. So I will wrap up first, and then Chris will toss it to you, Kim, and then Jason will end with you today. But I just wanted to say thank you. This has been such a lively live stream. Oftentimes when we do live streams on specific topics, we get a lot of non-specific questions, but there has been so many questions on eating disorders, orthorexia, and OCD, and how to differentiate. And it just really highlights the need for us to have more conversations in this arena. So thank you, Jason and Kim, for all of your incredible work and vulnerability in this area. It makes such a difference for the community. And I'm just so grateful that Chris and I could be a part of this today. Chris?
Yeah, a quick couple things. One, make sure to go to iocdf.org/conferences. You have to come out to Denver. I have to shout that from the rooftops because I'm more excited about that than Christmas. Second thing, I'm really excited. Adam put in the chat to follow him on Instagram. It's the Ultimate Food Fight on Instagram. He's been posting about his orthorexia journey. And my final word that I just wanted to say is I think what was the most difficult thing about having orthorexia, besides getting it validated from everybody, is I started to look healthy. I felt healthy, but I was miserable. And so the balance in treatment really let me still be a healthy person and happy. So I know sometimes when people have an eating disorder, orthorexia, they're getting compliments from friends like I did, compliments from family like I did, and they're looking in the mirror and getting hit on more, but you're miserable inside, and you can have both. So that's my final thought. You, Kim?
Yeah, no, I just would say, I think the main message I would say is don't be afraid to ask for help. If the person you're speaking to is saying that they haven't got the resources, don't be afraid to go to the next person and just keep looking until you can find resources to help you, because there is help for you, right? It may be that you have to go through a few therapists to get there, but that's okay.
All right. And I want to thank everybody. This has been such an incredible conversation, and I've learned so much today from just having the opportunity to chat with everyone. And I echo what Chris says. I live out here in Denver, so I'm excited to see everybody coming out here for the conference. And just to close on orthorexia, you're never alone, and everybody is worthy of help out there. So just like Kim said, advocate for yourself, keep asking for help. And we're all enough, and we're all worthy of treatment.
Well said, Jason. Well, everybody, thank you so much for joining us for today's edition of Lunch and Learn. And like Liz said, please, if you have somebody in your life, a family member, a friend, somebody that this would absolutely help, please make sure you go to the IOCDF's YouTube channel, so youtube.com/IOCDF, and share this. Liz, I'm going to have you take us out because you're always good at this.
Thank you so much. We'll see y'all next week. It has been wonderful, enlightening, and as always, the message we want to leave you with is that help and hope are always available.
Yes, we're back next week. You're right. Come back next Wednesday, 9 a.m. Pacific Standard Time, 11 Liz's time, East Coast, 12 time.
12 time. I like 12 time, Chris.
I meant to say 12 noon, but it came out as 12 time.